we ran this pilot project with the AI. First, we tested it against expert annotated notes, and we saw how well it performed. It found notes that were written by nurses and residents and radiation oncology and obstetrics on high-risk pregnancies that we never would have found.
Welcome to Leading Quality, the podcast spotlighting the people moving healthcare forward from the front lines to the C-suite. I'm your host, Jason Meadows. Dr. Deborah Unger and Dr. Matthew Gonzales are palliative care physicians at Providence, who have been deeply involved in the Institute for Human Caring's work to improve serious illness care at scale. Matt helps lead this work across Providence, and Deborah brings what I suspect is a rare combination of palliative care expertise and informatics training to the problem of how important clinical conversations are documented, found, and used. In this episode, we talk about goals of care conversations, those deeply important discussions about what matters to patients and families in the context of serious illness. Clinicians have these conversations every day, but in most health systems, they can be almost impossible to find later, buried across progress notes, consult notes, telephone notes, and narrative documentation. The deeper issue is how a health system moves from hoping these conversations happen to designing a reliable system that supports them, measures them, and makes them visible without reducing them to a checkbox. Providence's work has involved executive leadership, clinician training, nursing engagement, documentation redesign, and now AI models that can read millions of notes and identify meaningful goals of care documentation across 51 hospitals. This conversation is really about what happens when serious illness communication is treated not just as an individual clinician skill, but as a quality, informatics, and system design problem. This conversation is really about what happens when serious illness communication is treated not just as an individual clinician skill, which it is, but as a quality, informatics, and system design problem. Matt and Deborah bring the lived experience of building that system, learning from early missteps, and pushing towards a future where patient goals are easier to document, easier to find, and ultimately easier to honor. Dr. Gonzales and Dr. Unger, welcome to the show.
Thanks. It's a pleasure to be here.
Thank you so much.
So I'd like to start, as I often do, with a little kind of 10,000-foot view of both of your career paths up until now. Maybe, Matt, can you just kind of start me off with, what drew you into palliative care, serious illness communication, and any background you want to give me about your path so far?
Yeah, totally. I appreciate the question. If you had asked me would I end up here in this space 30 years ago, no. It was not some foretold thing where I was for many years longing to be in the space of providing better serious illness care. I think for me though, I've had a few fundamental experiences. One when I was actually very young. I had my favorite uncle die when he was just 27 and I was just 13. And his experience of serious illness and dying was pretty awful. And so I think very naively thought and took up the mantle really of motivating my life towards trying to make sure that other people didn't have that kind of suffering. And the way that I thought about that was more around trying to prevent people from getting ill. But as I've matured, as I've gone through medical training, I was struck very much by the fact that despite all of our advances, despite everything that modern medicine can do, and it is, to be sure, incredible, we really haven't changed the mortality rate of our species. It still remains at 100%. And so ultimately, there is something that will happen to all of us. And while some people may find that depressing, I find that very connecting because it means it's a universal human experience. And so for me, I've reframed and realized over many decades that his suffering, my suffering at the time was, yes, of course, about his illness, but it was also about the terribleness of his experience and a lot of the emotional, the psychosocial, the spiritual distress that was just really unattended to at the time. And so for me, I've dedicated my life to not trying to help us all live forever, which I know some folks are doing, but more around trying to recognize that when you're seriously ill, it takes a village, and that people have needs beyond, their anti-cancer therapy or their heart failure goal-directed therapy. And so I love that part of medicine and being able to sit with people and help systems be able to think about how we provide better holistic whole person care for folks.
Deborah, I wonder if I'm curious to hear kind of your rendition of how you got here to this point.
So I feel like I also would not have guessed that I would be here if you'd ask my high school self. I come from a family of people in healthcare. My father is a physician, pulmonary critical care, who ended up taking up the mantle of doing palliative care kind of before it really existed as a specialty, and was a hospice physician for many years before he retired. And my mother is a nurse. She ended up getting her PhD in nursing and nursing education, but was also a hospice nurse when I was young. So I grew up with discussions of healthcare in the family, and I was very adamantly against going into healthcare. When people asked me, what do you want to be when you grow up? I was like, anything but a doctor or a nurse, because they work too hard. But then kind of college age, I started thinking about what I wanted to do with my life, and being of service and combining the technology and the science of medicine really appealed to me. But it was kind of interesting going through medical training with the lens of palliative care being something that existed, but it's not really well taught in a lot of our medical education, especially 10 to 15 years ago. And so it was sometimes difficult, in medical school, when I had a class where you're like, oh, memorize all the nerves in the hand and then regurgitate it. But I'm like, but what about people? Can we take care of people? So I came out of that and decided to pursue palliative care full time, and did my fellowship, did a research year and a clinical year in fellowship. And then I went and was a clinical attending and faculty for a fellowship in Nashville for several years, but was always interested in technology. So that's kind of how I met Matt, and then ended up here at Providence with the Institute for Human Caring about 4 years ago.
Yeah, so I was going to ask you about that, but I'm glad that you brought that into the story, the connection that you and Matt share. So maybe Matt, can you elaborate a little bit more on kind of what the Institute for Human Caring is, and what your role is in it, and how you guys kind of got started together?
Totally. So the Institute for Human Caring was founded, 12 years ago now, by Dr. Ira Byock. Of course, many folks listening will know that Ira was one of the pioneers of the field of hospice and palliative care. He wrote a best-selling book, Dying Well, back in the 90s, that has been maintained a huge degree of popularity and resonance. And 12 years ago, he was looking and trying to figure out how we can cause meaningful change at scale. And so talked to a bunch of health systems across the country, focused really on the West Coast. But at the end of the day, Providence, which is where we're based, decided to step up and fund this big, audacious goal of creating something called the Institute for Human Caring. That's really a group, a collection of folks that come from all different disciplines, and not just clinical disciplines, but like professional walks of life from all, marketing folks, communication folks, software folks, data scientists, health system educators, clinicians. The goal of really trying to look at the experience of serious illness from all different angles and try to understand what the true barriers are to getting it right. Because while we've had a lot of success, we know that there are a lot of barriers to getting it right. And so our team really looks at it from multiple angles, trying to work within our health system, figuring out what those barriers are, how we create resources, how we create meaningful change, and that sort of like culture change package that we've been working on for the last 12 years is super fun. But as you might imagine, right, like it's not just all of those disciplines that I listed, but increasingly over that time, our world has become more and more digital. And we're not going backwards. We're not. Our society is not becoming more analog. So for us, one of the heavy investments that we've really made is in the digital sphere, recognizing that we are continuing down that path as a society within healthcare. And so trying to figure out and get out ahead of it and do that well felt really important. And that's been a challenge, to be totally honest. It's gotten a little bit easier and more exciting over the last 3 years with the advent of like modern AI and large language models. But it's been a key part of our journey really since the founding. And that's meant that we've needed to really bring in experts, really wonderful people that are not only trained in things like data scientists, but folks like Deb who are, duly trained and qualified to be able to do work both in the clinical space, so understanding what's really, meaningful and like how to really affect patient care. You can't go through training and take care of patients without getting some sense of that, but also understanding and knowing how technology works and how best to interface with it and how to think about it. So I would say it's been a real pleasure to that's been a part of our team now for 4 years. We met on Twitter back when it was Twitter. And we're exchanging tweets back then, back and forth about like, wouldn't it be cool if, and amazingly, when Ira retired from the Institute and I stepped into his role, it was a really easy decision to bring Deb on and to be able to help us move further faster.
That's great. And yeah, it's funny. As you were saying that, I think I still call it Twitter. Maybe I shouldn't, but that's. I'm
still learning how
what it's always been to me.
With it's X, right?
Yeah. That's great. And so I guess to bring a little more concrete detail to the meat of what we've been talking about today, you mentioned the Institute for Human Caring has tasked itself with removing a lot of barriers to this serious illness care that is so important. A lot of what we're going to talk about today is around goals of care conversations, how they're done well, how they're documented, how we know that they were documented, how we actually find the conversation in the haystack. And maybe you can, Matt, just staying with you for a second, can you kind of set the scene of where and when this kind of documenting of goals of care project started and how and why it started?
Yeah, totally. I think you very well described it as a needle in a haystack problem. All of us clinicians that have these types of conversations, whether you're a palliative care clinician like we are, or hospitalists, oncologists, no matter who you are, we're all having conversations around what matters to patients and families in the context of their serious illness. And that's really how we define a goals of care conversation within our health system. It's those really important what matters conversations when you're seriously ill. And it's not just like a sharing of prognosis. It's not just a conversation around what happens if your heart stops. It's like the more meaningful stuff, like, what does this mean in the context of your life? What does that cause you to worry about? What are the trade-offs that you're willing to go through for the chance of more time? All of those things are really deeply important. And we know clinicians are having those conversations, but they're really hard to find. Before we did this work, the down button was like my favorite button in our electronic health record, because you're just like scrolling down through every single note, right? Like when I come to meet somebody before I consult on them, I'm like, what have they already talked about with other people? And so you're reading the last like 20, 50, 100, 500 notes, depending on where you practice. And it's a lot of data for us to sort through. And it used to be very, very hidden. So we recognized really at the outset back in 2015 that one of the key things that we needed to do was make it easy to find these conversations, and also make it easy to measure whether those conversations were happening. Because it wasn't just that on the clinical side it was hard to find. We also couldn't find them on the back end to be able to say, are we really causing change to happen? Are we moving the needle on this? And so we developed really back in 2015 a simple standalone way to be able to know if those conversations happened and to be able to find them in the electronic health record. And, looking back on the technology that we used 11 years ago, it was the right technology at the time. Is it much better now, as you'll hear about? Yes, 100%. But fundamentally, that shift that happened in 2015 when we rolled this out, essentially being able to have a separate place to put these conversations and the single source of truth that collated all of them in one place, was huge, because it meant that I didn't need to go and read all those 500 notes anymore. I could reliably go and within 3 clicks of logging into someone's chart within the electronic health record, be able to find those conversations in one place. And that allowed us to be able to deliver, I think, better patient-centered care.
Yeah, absolutely. I'd love to claim credit as well for the conversation in the haystack metaphor, but I think I did steal that from one of Deborah's publications, an abstract you published last year. So I just wanted to give credit where credit was due. And yeah, it's an incredibly difficult problem. I think there's probably so many clinicians listening who have had the experience of trying to pore through notes and find, what was discussed, where was it discussed, where in the note was it documented, does the substance of the note match the substance of the conversation? And I imagine that's a lot of the work that you've had to do. I understood, and I'll include links to the relevant articles, including the New England Journal Catalyst article. But I understand that one of the things that moved the needle in this work was to have Providence place this as a system priority rather than it being kind of just a palliative care side project. And I'm really curious to know how that came to be and who had to, how you kind of convinced the right people to make this a system-wide priority.
Yeah, Jason, I think you're totally right to say that was critical. And I think when we talk nationally about this, people are always like, that is a big question that we get asked, like, how did you do that? Probably, maybe from the outside, if you're sitting in a different organization, it felt like a larger ask. But at the time in particular, at the founding of the Institute for Human Caring was founded directly at the CEO level for a reason. And so there was institutional will, there remains institutional will, I should say, because it's really aligned with our mission, vision, and values of this organization. There's a saying within Providence that's, they call it the Providence Promise. It says, know me, care for me, ease my way. What I would say is I think most of our employees would be able to say that sort of tagline, as it were. But it really resonates with people that in order to really best take care of folks, we need to know and understand who they are. It's the know me part. And so it aligned very much with sort of the high level vision of the organization. And it happened at a time where is increasingly being recognized that people in American healthcare were dying badly, that we weren't attending to what needed to be talked about. We weren't attending to their symptoms. And so it was actually relatively easy to say, we need to make this better for patients and families. So a lot of it was organizational tie-in, will, and alignment with mission.
I wanted to pause for a moment to invite you into something I'm starting with this podcast. If something from this episode connected with your own experience, where you've seen it work or not work, I'd love to hear about it. There's a short link in the show notes where you can share what you're seeing in your own work. It takes about a minute. I read every response, and over time, I'll be sharing what we're learning together in future episodes and in other ways, and giving shout-outs during future episodes to people in the community who share ideas that really move the conversation forward. If you're up for it, I'd really value your perspective. Thanks.
I'm also curious, Deborah, from kind of an informatics perspective, what did goals of care documentation look like in kind of the early days? What was problematic about the way things were structured from an informatics perspective, and how has that evolved over time?
Yeah. As Matt was talking about, one of the biggest problems from a data science and informatics perspective around these conversations is that there's no sort of one way to find them on the back end. They're written narratively in text. It can be in your history and physical note. It can be in your progress note for the day. It can be in your consult note. It can be in a telephone note. It's not just palliative care. It's the hospitalist, the oncologist, and the surgeon, and the primary care doc. So it's not inpatient or outpatient. It's not just physicians. It's chaplains and social workers and nurses and respiratory therapists and physical therapists. So it's not one discipline. So how do you find these? And so that was sort of the first impetus of creating these standalone goals of care notes that use the technology at the time, which was essentially a form of check boxes that was based on the Serious Illness Conversation Guide out of Ariadne Labs, which the Institute partnered with, to create one place where people could document these conversations, but then we could also find them later. We could find all the notes that were goals of care notes. And that, I think, was also an important part of almost the perfect storm, or the opposite of a perfect storm, to allow for this to be an institutional metric that was recognized at the executive level, because you can't ask for a metric to be created if you can't measure it. And so we were able to say, hey, not only can we find these documents where people talked about these important conversations and put them in front of clinicians, which is probably the most important thing, but we can also take it and show which patients had them, at what point did they have them, who is having them. And so we can actually show what quality measures are associated with having those conversations, because if you can't find them, you can't associate them with any outcomes. So that was a really big part of how it kind of came to be so recognized as an institutional priority as well.
Yeah, and so this the Serious Illness Conversation borrowed from Ariadne Labs, and you mentioned kind of how it had a very nicely kind of standardized templated version of this. I'm trying to picture this in my mind's eye as you're describing it. Is this, as a clinician, is this like where I go to create my notes? So I'm creating a note now as I would any other day, and I do a smart phrase, dot phrase, pick your lingo, and it pops into a note. Is it like a whole different section? And I have a follow-up question too.
Yeah. So when it was originally rolled out, it was a whole other section. So it was not where you would do your normal notes. We had created, Matt kind of said this, a single source of truth, where we put everything related to advanced care planning. So we had information around code status, we had information around POST forms, post or most or K-POPs or whatever you call it, and advanced directives and healthcare agents. But then importantly, we also had all of the documentation around goals of care. And from that, you could create the goals of care note. Now, I don't know if this is part of your follow-up question, but one of the pieces of feedback we got was that that was burdensome to clinicians, that it was not as efficient and easy as people would like it to be to go to another place to document their note. They didn't want to have to do that double documentation. They didn't have to write their progress note for the day and then go fill out a separate sort of template around goals of care. So our second iteration of documenting goals of care was to integrate it with sort of your daily documentation through a nested layer of tools, but essentially is a smart phrase, dot phrase, pick your smart term, trademark epic. But you could build that into your progress note template, or you could add it, just by writing .goc. And then there were a couple other quality initiatives we did building on top of that, but that was kind of the direction we went originally. We started with a standalone note, and then we moved to an integrated documentation method.
Yeah, you covered it pretty well. So yeah, really it was around, my follow-up question was just around clinician reaction, clinician adoption. It's kind of usually where my QI brain goes, is like, what's this workflow going to look like, and how happy are people going to be with it?
So this is the right question to ask, because like we all, I mean, like we're one group in a large health system. If similarly, like the cardiology group, the hospitalist group, the nephrology group, like if everybody has like one thing that they want us to, each like clinician to do, it becomes unmanageable. And we're all struggling with too short of an amount of time to be able to see our patients and interact with them and take care of them in the way that we want to. So it's exactly the right thing. And why I would say even those technologies have had their limits with us. And that's why I'm like so grateful and in awe every day of the work that Deb's been doing to integrate AI into our work, because I am excited that it feels like we're finally at the place where we can like jettison and abandon some of the teaching people how to use the electronic health record correctly, and to really just get back to like taking really good care of patients.
Yeah, there's definitely a lot of, as you say, training people how to use the EMR, correctly, or the new version of correctly, that we can kind of leapfrog when things become a little bit more real-time, interactive, and intuitive. And I'm curious, so I think if I remember this correctly, early on, a lot of the work focused on training clinicians to do better goals of care conversations. And that, I think that remained part of the work, but maybe there was more added to it. I wonder if you can go into that, Matt.
Yeah, 100%. It's really critical. So as I sort of alluded to, we have lots of different folks on our team, and informatics is a key part of that. But we also recognize one of the barriers was that clinicians didn't get enough training in their like formative training, med school, nursing school, whatever, to have these conversations and feel confident about them. I myself went to med school in the early 2000s, and I got 15 minutes of role play education on this total. And that's what I was expected to be able to go and then break bad news to patients and families with it. I would suggest there really needs to be a broader shift, and I know there is some broad shift at the medical education level and nursing education level that's happening. The truth is that medications have changed dramatically in the past 20 years, and yet communication is still really essential. And so I think that fundamentally, we need larger policy change around helping people to communicate better. Just because you can talk doesn't mean that you can communicate well. And so we have spent a large amount of time in infrastructure. We've trained nearly 5,500 of our clinicians in the Serious Illness Conversation Guide over the last 10 years. We call it not Serious Illness Conversation Guide. We kind of custom branded it for ourselves. We call it ACT, Advanced Communication Training. We specifically chose those words because it turned out when you call it communication training, nobody really wants to show up for that, but you add the word advanced in front of it, and it suddenly everybody feels much more comfortable coming to a class because now they're not attending basic communication training. So we have nuanced it over many years. We used to do a 2.5-hour live in-person class. We've now pivoted several generations later from that to some online interactive modules and sort of like triadic role play via Teams or Zoom or whatever the platform folks are on. Most recently, we're in another generation change of rolling out a AI-based conversation simulator that has AI sort of trained patients to respond as a patient would, so that clinicians can interact and really practice these techniques. Try saying, I wish, worry, wonder, or teach back in the safety of a role play like environment, whether that be human to human or human to AI. It feels really essential to getting this right. Like the last thing we wanted to do was create some big quality project where we said, we have to measure this. We're expecting these communication or expecting these conversations to happen, and not better equipping our clinicians to have those conversations. It felt like doing that would, quite frankly, set up patients for the potential for harm.
Yeah, and so the training and kudos on realizing that advanced was going to be the unlock there. I imagine the attendance probably shot right up as soon as you added the advanced on there. I'm curious then, once this training was up and running, did you notice that did that move the needle enough? Were there more layers that had to kind of come on top of that to keep things going?
Yeah, there's definitely many layers to each of these things, and I think that's a lot of what we focus on in the Catalyst paper. Of like, we've had a lot of success. So just to say, last year on the Star Health System, we had 120,000 of these goals of care conversations recorded. Over the last number of years, 85% of patients with an ICU length of stay of 5 days or more had a goals of care conversation that met quality conversation definition. We're a large health system, right? Like we have 51 hospitals across 7 different states. So it's a huge effort, and it's taken many different levers. One thing that I found particularly fascinating was, and this was, I'll admit, like an early mistake for us, and part of it was the narrow-minded vision of like myself and others around the leadership of the Institute being a little more physician-focused, and that's what we focused early on physician training. And that did not move the dial at all. And we did everything we thought we were supposed to do. We like paid the docs to come in. We bought them fancy meals. We provided CME and like MOC point, like anything you could possibly think of. But they were kind of voluntold to be there. And so the barrier to resistance was relatively high. What shifted the needle for us in our pilot hospitals where we started was training the floor nurses. That fundamentally shifted things. And over 2 years in those 2 hospitals, we trained 91% of the acute care nurses with floor, step down, ICU at the adult and on the adult side of the hospital. And that shifted things. And I think it's because nurses are really good at quality improvement. Nurses are really good at process. And so, for instance, embedding in reports, the sort of report structure within the hospital for nurses at the end of their 12-hour shift or the beginning, depending on your perspective, the question, were goals of care discussed for this patient? Or later, what were the goals of care that were discussed? It was really important at causing that shift change. So admittedly, like if folks are listening to this and wanting to copy, yes, of course, the informatics super important to be able to find and measure. Yes, of course, having leadership buy-in and being able to ensure that this is actually something that people care about. But approaching it from a true interdisciplinary spirit and recognizing that, like, you can't just see it from your own discipline perspective. Like, we have to reach across and figure out, like, how to do this well with others.
It's exciting to hear how different, I can just kind of imagine the feeling, like how different things became once the nurses started to get involved, and how that may have had ripples out to other people that those nurses got to be in contact with.
Yeah, and I had the privilege of, like, being in the hospital at the time. Like, I was kind of deployed as, like, working in those hospitals and trying to figure out what the real problems were. It was fascinating to me, the shift that happened. And we got really creative, So one of the things that we did for it was like 4 months, we had a nurse that was, like, really talented at these conversations. And unfortunately, she was injured and was on modified duty and wasn't able to, like, do all of the normal bedside nursing care. And so we worked with the hospital leadership, and she did goals and care conversations all day. And she was quite happy to do that because it meant that she was still getting to do something more than, like, typical modified duty of, like, restocking, the back closet. She was still interacting with patients and families. She was still, like, able to do things and, like, helped coach actually some of the other nursing staff around doing this. So I think another key example of success for us was having people that really cared about the initiative as, like, clinician champions in the actual hospital to learn, like, what works well and what doesn't.
So I'm curious, and this maybe goes to both of you, but I think I'll start with Deb. One of the tensions that I think that you can kind of naturally imagine. I think a lot of people would think when they're trying to be templated or having check boxes about something that is so deeply human, that there's a bit of a tension there. And I'm curious how the two of you think now, and maybe if your thinking has changed at all over time on how you document these conversations in a standardized way without reducing the conversation to a checkbox.
Yeah, it's such a good question. I spend a lot of my time actually thinking about that question because I think we all know that as soon as you reduce a process to a metric and you put a checkbox on it, that you're at risk for making it just a checkbox, that people check a box and they're like, I'm done, and abdicate, like, the rest of their responsibility. So what we did, this has been a very iterative process as culture has changed, as technology has changed. But when we started with that sort of integrated note tool, one of the things that we quickly realized is that it is very tempting to do that checkbox, do the minimum. And so when people were putting in notes, sometimes we would get things like, oh, the patient was sleeping, or I tried to call their family and no one answered. And we're like, well, that's not a goals of care conversation. So the next iteration included 2 checkboxes that went through an extreme round of governance and clinician input around what would be the most meaningful information, what was sort of the minimum requirement for what we would consider a quality goals of care conversation. And what came out of that is that you pretty much had to document who was there, who was part of the conversation to at least satisfy that you had a conversation with someone, and an overall goal for their medical care, which could range anywhere from do all the offered aggressive medical interventions to focus on comfort with some middle ground for time-limited trials or, some interventions that would not be acceptable. And then we kept the rest of that documentation completely narrative full text. So as long as you kind of documented at least those two pieces and then had some details of the conversation, we were capturing that information. And that really helped because it got rid of the I went by the room and no one was there kind of piece, and really got people to realize this had to be a full conversation, but it kept that flexibility and fluidity of still being able to document in a narrative format. Now, I will say over the years, to your point and your question, there's still some pushback around, well, we would get feedback saying basically, oh, we have these conversations all the time. We were busy and we didn't use the dot phrase, or, it's a new attending. They didn't know to use the right template, or it was a fellow and they're just rotating here for a week and they didn't know about it. And how are we supposed to train them to do that? And so that is where we were kind of stuck for a few years. And then there was this revolution with AI and large language models. And so what we decided to do is leverage that technology, because the whole idea behind large language models is they're so good with words and language that we essentially set up an AI model with a prompt. So we said, hey, AI, you are now a palliative care doctor. I want you to read this note for me in my place and tell me whether the note has goals of care, conversation, documentation within it. And we gave it some boundaries, some rules. We said, if it's just a conversation around code status, that doesn't count. If you're talking about a conversation that happened, yesterday or a week ago, that doesn't count. It's only if it happened today. And we kind of defined a little bit about what we wanted for goals of care based on our prior quality work. Someone had to be present for the conversation. There had to be some details about the plan of medical care. And we ran this pilot project with the AI. First, we tested it against expert annotated notes, where basically we had interdisciplinary team of clinicians, 2 physicians, social worker, and a palliative care program manager read notes and say ourselves whether they contained goals of care information. And then we had the AI read it and we saw how well it performed. After we saw that it did pretty well with that, we turned it into a pilot project here at Providence and ran it for every inpatient note written for 6 months at 4 of our hospitals. And then we manually reviewed the notes that came out of that, the AI had tagged as containing goals of care information that did not contain our old method of documentation. And it did really well. It did surprisingly well. It found notes that were written by nurses and residents and radiation oncology and obstetrics on high-risk pregnancies that we never would have found, because we don't always think to train people in using the .goc in those specialties or disciplines, or we know there are education gaps. And it was just amazing what came out of that. We actually did some estimates of if the AI ran for our entire system for a year, it would have found not only all the regular notes that would have been documented in our old dot phrase way, but an additional 7,000 notes, goals of care notes for the year. And so with that, we got full institutional buy-in, and we launched it Providence-wide, so to all 51 of our hospitals last December. And we're continuing to monitor it. It's done an amazing job. I will say in the first month and a half, it had read something like 5.7 million notes, found 30,000 goals of care conversations documented, and it was doing it not only in traditionally documented, typed or dictated notes, but also in ambient scribe created notes. So we're kind of creating this really cool full loop where you can walk into the room, your conversation is heard by the ambient scribe. The scribe writes your note, and then the AI determines the quality pieces of it that are present without you having to use a single checkbox, a single dot phrase, a single template. And it's really cool. I just think that it has a lot of potential for some of our other projects. But yeah, we're really proud of it.
Yeah, I mean, it's exciting that there is this, what to me, I guess, as another palliative care clinician amongst the two of you, an unlikely friendship and partnership between, AI, palliative care, informatics. Who the heck ever thought that all of these different fields were going to join forces in such actually, in retrospect, probably an obvious way, right? Like the thing that the large language models do best is language, and that's the thing that's been so elusive. And it also sounds like what I picked up on there as you were describing it is that using these AI models helped you to realize you didn't even have the right denominator, because the goals of care template you were using was the denominator until we realized there was a whole bunch of other non.goc notes out there. What a cool experience. Matt, is there more to add? The initial question was on how we document without reducing to checkbox. I think we went so far beyond that, but I'm curious to hear your thoughts if there's anything else there.
Yeah, I think we've just gone so far beyond this at this point in time, which is wonderful. And I alluded to this earlier, but I am so happy to stop like this teaching people the right way to put things in. I would have so many conversations of like, well, I had the conversation, but I didn't put it in the way that was like the approved way. And like, so you're just measuring the checkbox. You're not actually measuring whether I did it. And this goes beyond that. Or I had the conversation, but I forgot to like type goals of care. So like, you can't tell me that I'm not doing it. And it turns out when we use an AI tool, those clinicians that said they were doing it, they're not doing it as often as they think they are, because it's not meeting the same sort of quality definition. I will also point out for those that are listening and think, oh, well, like I could never do this. That's got to be really hard to do. There were some challenging pieces for sure, but clearly they're solvable. We're running this model across, all of our hospitals, and it's reading millions of notes. And it's not that costly. So our cost estimate for the year is that it's going to cost us $27,000 a year to run this, which, yes, is dollars for sure. But for a health system of our size, $27,000 is not a lot of money to spend on trying to ensure that the stories, that what matters to people, that is delivered to clinicians and in one place so that people can read it and understand it and figure out how best to care for people. So it is a solution that feels like it wins for us around a lot of I'm going to say checkboxes, because it gets us away from the checkboxes. And now the question I have is like, how soon can we deploy this across all of our like outpatient clinics? Because that's the next space that we need to move into.
Oh, that's so cool. As I was reading through in background for this interview, I think at least in your publication, you described using, I think, ChatGPT 4.0, and I, like probably many, many people out there, are paying attention to the version numbers as they come out, with 5.5 just coming out 6 days, I guess, before we recorded this. It was April 23rd, I believe. And that's a number of steps up, and a big leap from what 4.0 was, even though it was really great. Are we and even with 4.0, you were getting, incredible specificity and accuracy. Are you guys in a place to be nimble enough to use new models as they're coming out? And is that reaping any additional gains, or is it, was it already good enough?
Yeah, that's definitely on our plan to do, is to test the validation with further models. We haven't gone beyond 4.0 at the time because there is a delay in terms of when those versions come out for sort of commercial public use and using it in healthcare, because it has to be approved to use for all of our, privacy concerns and behind the firewalls, and that it works with all of the infrastructure we have. We actually had a little oopsie, because we had our model at one point auto updated to a new version, and then one of the data definitions didn't match because it had updated in the new version, and we were like, oh, whoops. So it is something that we're very aware of. We're trying to do deliberately, though, not letting it sort of do that auto updating any further. But I think one of the big things is that as you said, we were getting such a good performance from the models that we had, that there isn't a huge push to use the newer versions, particularly because if we continue to use a version that did well and is integrated, into our systems, and the price drops, that's even a better, deal for us, because as the newer versions come out, the price per token and things like that go down on the older versions. So it's kind of a win-win for us.
Oh, that's so cool. So, I'm also thinking, I noticed that you set kind of different levels of aspirations for what percentage of patients meeting the definition of ICU stay, at least 5 days, have these documented goals of care conversations. And it was a more modest number to begin with, and then scaled up, I believe, at 90% at the highest level, which Matt, you already said was it met and exceeded at system-wide, and I think almost at every individual hospital, which is just, really incredible. It makes me wonder, you had this great leadership support to begin with. The project has been evolving and has really made some great gains. Does that start to change a lot of the leadership conversations? There's a whole lot of metrics we can point to that don't see such incredible success. And the fact that there's been this meteoric rise from, certainly much less than 50% to greater than 95%. Does that really, change the leadership conversations that are happening?
It does. And I would say, so we graduated actually just a year ago from being a system level metric, not because people didn't think it was important, but because we had exceeded the goals for so many years in a row that people were like, well, why are we still measuring this? If we're going to put quality bonuses on this, we expect to meet it rather than stretching in other areas. I was nervous when that happened, because when something falls off like that, and it's been on for years, people assume. But I would say we have continued to be able to meet those expectations. And I think it's in large part culture change. I didn't want to say that years ago because I wasn't sure we were there yet, but it feels like culture has shifted. And that's not to say that we get it right every time, but I think we get it right more often than we don't. And I also think it's because we at the Institute have a great team. You're listening to Deb, she's brilliant. Melissa Forbin, who's our senior program manager that oversees this program, is incredible and smart and passionate and keeps working on this every day. And so, I had a mentor that shared that life is short and that you got to work with people that you like or even love. And so I think part of our secret sauce too is that we've created a great team and have really great people that are passionate about this. And we continue to keep moving forward.
There's so many more avenues that I wanted to go down with this conversation, and I think we could keep it going for quite a while. But I wanted to round out the conversation to hear from both of you what you think this work looks like 5 years from now, if it's reaching its highest 5-year aspirations? Maybe Deb, we'll start with you.
I have a lot of aspirational thoughts when it comes to this, but I think we're really reaching this inflection point in both our documentation processes and then how we measure outcomes and quality from that documentation. Because as I said, I think it's becoming a much more seamless circle. I used to talk, when I was talking about quality and documentation, I said there are 3 things that have to happen. First, for we're talking goals of care conversations, the conversation has to happen. And then the second is that it has to be documented. And then the third is that you have to be able to find it later. And without any 3 of those 3 things, it's a broken system. But with this advance in technology, all of those become seamless. You walk into a room, the conversation is recorded, so you don't have to say later whether it happened or not. It either did or it didn't. The documentation happens without you having to sit down and then be, interrupted by another consult and, shorten your note and be like, I talked to the patient instead of writing down the full quality of that, the richness of that conversation. And then you don't have to use a checkbox for us to be able to find it later. And so I think we're going to go into these systems where the way we look at quality fundamentally changes. And I think it's also going to be amazing to see the ways that then feeds back into our education and even real-time coaching. Matt mentioned earlier, we're working on an AI communication skills training product. What if in real time, as you're having these conversations, you could have a little bug in your ear being like, hey, you're using a lot of medical jargon and they seem really mistrustful. What if you tried saying this? Or, hey, 2 days ago, someone had a conversation and they were very adamant they didn't want to talk about prognosis. Why don't you not bring that up today? And you had a little, helper in your pocket for improving these kinds of conversations. Because as Matt said, this is something that we haven't really changed our training on in years, but it's so important. People are gonna, I think, the classic quote is that, people don't, remember what you said, but they'll remember how you said it. People will remember and respond when we communicate well. And so having something that actually helps with that, be that either in our education or training or in sort of that real-time format, I think it's just going to be a complete change in the way that we look at this.
Yeah, I can't wait for that vision to happen. I'm excited about it for sure. And I agree, all of that is potential. I think a lot about too the future and the gaps that we still have, which is we can say a lot of these conversations happened, but we also can't yet demonstrate what that means for patients and families. And that is the gap that I think that really bears closing with all of these techniques. And I think we're really close. For the first time, truthfully, in my career, it feels like we or someone else will be able to accurately and adequately measure whether goal concordant care was provided. And that's really exciting.
Wow. I mean, what an incredible success and what a high bar to reach on both the informatics technical fronts and the human-centered care fronts. I'm really grateful that you guys would take this time to have this conversation, and I want to give our listeners the opportunity, if they wanted to connect with you or to follow your work, to know where they should do that, and we can include appropriate links. Deb, where would be the right place for people to find you?
Probably email is actually the easiest, but I also have a Blue Sky account, so I will provide that link.
Yeah, for technical folks, like we're like email is still like our where we mostly are, and not us on socials. But
At least it's not
appreciate
like by
the
fax
nod.
machine, Matt.
Yeah, okay, that's fair. Yeah, our fax number is 888-555-1234. No.
So you, same question for you, Matt. The email, is there anywhere else that we should?
I think email's great. I'm occasionally on Twitter still, but that's just mostly very, very, very ad hoc. So we'll definitely send you our emails, Jason, and folks can reach out there.
Beautiful. Well, thank you both for this deep reflection on what has been a really incredible effort, as you said, since 2015, Matt, and really excited to see where this goes. The intersection of QI, palliative care, and AI was not on my radar a few months ago, but I'm so glad we connected for this conversation. Thank you both so much.
Same. Thanks for your time.
Thank you.
Thanks so much for listening to today's episode of Leading Quality. If you enjoyed the show, please take a moment to like, subscribe, and share it with someone who might find it useful. You can find all our episodes at leadingquality.buzzsprout.com or in your favorite podcast app. The show was written and hosted by me, Jason Meadows, edited by Milan Milosavljevic, and produced by Thrive Healthcare Improvement. See you next time.